Bueno, muy buenos días a todos. En primer lugar, quiero agradecer la presencia de todos ustedes ahí, del otro lado de la pantalla. Y al mismo tiempo, les quiero dar unas palabras de bienvenida, para lo cual algo me he escrito. Es con mucha alegría que en nombre del comité organizador del XVII Congreso Uruguayo de Medicina Intensiva y XIII Congreso Uruguayo de Enfermería en Cuidados Intensivos, le doy la más cálida y cordial bienvenida a nuestro Congreso, que será el Congreso de todo el equipo de trabajo multidisciplinario de la terapia intensiva. No es un congreso más que reúne a los intensivistas de nuestro país en torno a la presentación y discusión de aspectos y de tópicos controversiales y actuales de nuestra especialidad. Tampoco se trata de un evento más en el cual, como cada 2 años, todos nos encontramos para compartir un tiempo juntos. En este último tiempo, y en particular durante este último año, que ha sido un año difícil y desafiante para todos, la cual la humanidad, como pocas veces antes, se ha visto enfrentada a una tremenda, terrible enfermedad. Y en la lucha contra esta pandemia, todo el equipo de trabajo interdisciplinario de la medicina intensiva ha debido enfrentar dicha enfermedad. Ha sido un tiempo duro donde todos hemos estado sometidos a sobrecarga laboral y emocional, y tristemente también ha sido un tiempo donde hemos perdido a algunos de nuestros colegas. La SUMI, la Sociedad Uruguaya de Medicina Intensiva, como colectivo médico durante esta pandemia, ha tenido que enfrentar enormes retos y al mismo tiempo ha sido una organización que brindó en todo momento una ayuda clave en el manejo de la emergencia sanitaria por la pandemia COVID-19, siendo un pilar en la ayuda sobre la toma de decisiones. Nosotros, los médicos intensivistas, y nuestra especialidad toda ha adquirido una notable popularidad y hemos sido, una vez más, de gran ayuda para toda nuestra sociedad. Debo confesarles que, al igual que todos ustedes, me siento profundamente orgulloso de ser un médico intensivista. Este congreso es especial por muchos motivos. Además de celebrar los 50 años de la medicina intensiva en nuestro país, en este país que fue pionero en terapia intensiva en América Latina, y celebrar además los 40 años de nuestra sociedad, de la SUMI, celebramos los 50 años de la Cátedra de Medicina Intensiva y del CTI universitario del Hospital de Clínicas. Acá quiero hacer una mención especial, pues la cátedra que ha formado a todas las generaciones de médicos intensivistas de nuestro país representa algo muy importante para mí y para mi vida, pues en los últimos 28 años ese servicio ha sido una parte grande y trascendental de mi vida. Pero también este 17º Congreso se da en un año particular para nuestra cátedra, pues en este año, de los 50 años del servicio, el profesor Alberto Biestro, quien la ha dirigido a lo largo de los últimos 10 años, ha llegado a la edad de cese, de retiro de la Universidad de la República. Entonces, en este congreso que se da en un momento especial, el mismo implica un homenaje a toda nuestra sociedad, a nuestros jóvenes médicos, a la cátedra y también al profesor Biestro. Debo confesarles que estoy convencido que hemos organizado un gran congreso, con un programa académico que muestra un contenido actual, provocador, el cual abarca los tópicos más recientes y controversiales de nuestra especialidad, los cuales hacen al abordaje diagnóstico y terapéutico del paciente crítico en la práctica diaria. Por todo esto, junto con el comité organizador, estamos profundamente orgullosos. Nuestro 17º Congreso comenzó en el día de ayer con 4 cursos precongreso, incluyendo un curso refreshment, el curso de abordaje metabólico y nutricional del paciente quirúrgico crítico, el curso de ultrasonografía y el ya clásico curso de ventilación mecánica. Afortunadamente, estos cursos han tenido una muy importante y activa participación. Durante estos 4 días de congresos, contaremos con la presencia de 73 invitados internacionales provenientes de los más diversos países de América Latina, de los Estados Unidos, del Canadá y de Europa, y además con 78 ponentes nacionales, por lo cual este evento constituye un congreso inédito, sin precedentes, para nuestra medicina intensiva. Tendremos funcionando 3 salas en vivo y en simultáneo, transmitiendo un total de 22 mesas de médicos, 3 simposios de la industria, más de 15 conferencias, los cuales abarcan la mayor parte de las áreas temáticas de nuestra especialidad. Y es con profunda alegría que les confirmo que hemos llegado a un total de más de 500 inscriptos, con más de 150 inscriptos en los cursos precongresos. Por su parte, tendremos, como cada año, la jornada de médicos residentes, a la cual desde ya están todos invitados. Además, habrá una sesión para la presentación de trabajos libres y, finalmente, una premiación a los mejores trabajos científicos presentados al Congreso. Llegar hasta este día ha sido un largo y tortuoso camino para este comité organizador, créanme. Dificultades en la obtención de la colaboración de la industria se sumaron a la imposibilidad de poder realizar un evento presencial, el cual lo estuvimos evaluando hasta hace poco más de un mes atrás. Quiero en este momento, y para ir finalizando, extender algunos agradecimientos. En primer lugar, agradecerle a todas las empresas que con sus aportes hacen posible este evento. Asimismo, a todos los colegas que colaboraron en la elaboración del programa académico, los que han dedicado parte de su tiempo a generar los distintos contenidos del mismo. Vaya también un agradecimiento muy especial a mis compañeros del comité organizador y en particular, que la tengo enfrente, a una mujer por todos conocida que con su forma de ser me demostró que es una persona muy querible y una gran compañera de ruta. Al mismo tiempo, agradecerle a María y a Valeria, las chicas, entre comillas, de Atenea, por su profesionalismo y su invalorable colaboración. Al mismo tiempo, quiero hacer llegarle un sincero y apretado abrazo a cada uno de ustedes, médicos intensivistas, residentes, posgrados, licenciados de enfermería, auxiliares de enfermería, licenciadas de nutrición, neumocardiólogos y fisioterapeutas, por hacer posible que este congreso que alguna vez soñamos hoy sea una realidad. Finalmente, quiero agradecerle a mis amigos y a mi familia por haber estado siempre ahí y por haberme hecho el aguante durante este tiempo. Entonces, pues, apreciados colegas, compañeros y amigos, los invito formalmente a disfrutar de nuestro 17º Congreso de la SUMI, y los invito desde ya a todos a que sean parte de la celebración el próximo viernes a la hora 19:30 en la Torre de las Telecomunicaciones, donde todos juntos celebraremos los 50 años de la medicina intensiva en nuestro país, los 40 años de nuestra sociedad y donde además homenajearemos a nuestros jóvenes residentes y posgrados, así como también al profesor Alberto Biestro. Un fuerte abrazo a todos, muchas gracias. Entonces, ahora vamos a proseguir con la conferencia de apertura de nuestro Congreso. Es para nosotros una enorme alegría presentar al profesor Louis Vincent. El profesor Louis Vincent, no tengo su currículum en este momento frente a mí porque lo dejé a unos metros de aquí, pero el profesor Louis Vincent es profesor de cuidados críticos de la Universidad Libre de Bruselas, director de la unidad de cuidados intensivos del Hospital Erasmus de Bruselas, en Bélgica. Louis Vincent es editor en jefe de Critical Care, de Current Opinion in Critical Care. Ha sido presidente de la World Federation, de la European Society of Intensive Care Medicine, del International Sepsis Forum. Ha escrito y ha participado en más de 1.300 artículos con peer review y, bueno, es uno de los intensivistas más importantes e influyentes del mundo, por lo que para nosotros es un inmenso honor poder contar en esta ceremonia de apertura con la presencia de Louis Vincent, que nos va a hablar por qué él ama la medicina intensiva y nos va a dar su visión sobre el hospital y la terapia intensiva del futuro. Adelante.
Hello, hello. Good to be with you and discuss this important aspect. Why I love critical care medicine. I have no conflict of interest. But the first element is that we have a wonderful medical specialty. As I tell my students, if you don't like intensive care medicine, you don't like medicine. And you know, we need specialists, exactly as we need specialists for cardiac surgery. We cannot just take any surgeon. It's the same for critical care medicine. And we have known for many years, this was very popular at the end of the last century, that an intensivist can have a positive impact on outcome. This is now well accepted. And if someone tells you it's more costly to have a specialist, tell them no, 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 no. It is very cost effective. It can decrease the costs of intensive care medicine. And there have been studies showing that the sooner the specialist is available, the better for the patient. In mechanically ventilated patients, if you have a delayed consultation with an ICU specialist, the risks of dying are increased. And this was the debate between closed and open ICU. An open ICU is an ICU where consultants can write orders. Not good. We need closed intensive care units with only ICU specialists writing orders. But this is now well accepted all around the globe. And what I like about critical care medicine is the diversity. We have many different cases. In the past, this is history. There were anesthesiologists in charge of the ICU, and there were internists in charge of the ICU. And this was, medical ICU, surgical ICU, this is over. Now, intensive care medicine is multidisciplinary. There is no longer, or there should no longer be, any discussion between anesthesiologists and internists. And even surgeons can have their role to play, provided that they have enough experience and training. But a surgical patient is a medical patient with a scar. The problems are the same. We speak about sepsis, respiratory failure, shock, renal failure, delirium, etc. So why would it be different? when it's a medical patient and when it's a surgical patient. We need multidisciplinary intensive care units. They should be all together. I know in the US, it's not like this. They have many ICU beds, and there are still territories for trauma, for liver, etc. But in most places in the world, we have now general ICUs or general departments of intensive care medicine. We should not have separate intensive care units, or at least they should be in a single department with a single responsible person. But the problem is, if there is no bed availability in a specialized ICU, the patient will have to go in another ICU where people do not usually treat this kind of patients. And it's well known that the quality of care becomes affected. You don't want to be a neuro patient in a cardiac ICU and vice versa. And at the end of the day, for other aspects, management is the same. Fluid management, nutrition, heart failure. Why don't we combine all this? In the US, they still have neuro ICUs. We are neuro ICU doctors. This is obsolete. Neuro patients can develop problems like others. So, specialty ICUs, in my opinion, should not be individualized. And again, that's usually the case around the globe. At our institution in Brussels, we have combined all patients in the 5 intensive care units. They just have a number. And this is easier for management. You make sure that the workload is comparable in the 5 units. Now, in a single ICU, you find a variety of problems, and that's wonderful. It shows that we have to deal with different patients, one patient being different from the other. Do not try to treat them all in the same way. Yeah, we speak about sepsis. Yeah, because it helps to really understand that we will speak about multiple organ failure, we'll speak about infection. We like to speak about the ARDS because we will speak about the respiratory management, look for sepsis, etc. But these are not diseases. No. These are just syndromes, and there is no specific treatment for ARDS or sepsis. Yeah, in sepsis we need to give antibiotics. Yeah, but that's for infection. Do not forget the word infection. It still have a place. How many patients with pure renal failure do you see a year? Only renal failure. Very few. Patients usually have a combination of problems. And that's what makes intensive care medicine interesting. Don't speak about SIRS. That's not helpful. We decided to throw it away because it was creating bad problems. A patient is not a patient, is not a patient. Are all different. And to take care of them, hopefully, we have a team. There is no other discipline where the team is more important than in critical care medicine. We are all together around the patient. We bring our clinical skills, but also our communication skills, because we cannot be there 24 hours a day. So we need to rely on others, and others will bring some important information to us. So we need to really develop this team approach, as we have done here with a picture of each member of our department. And if you count the number of people working in your department, it's big. In our institution, it's the biggest department in the hospital with more than 200 people. Of course, many nurses, but still many doctors, physiotherapists, etc. And nurses are really essential. They make the quality of the ICU more than the technology. You may have beautiful ECMO machines. You need good nurses before anything else. This is an old slide, but I love it, showing our head physiotherapist here. Old slide showing our biotechnicians. They do a good job. We need a psychologist, and we need a pharmacist going over the drug prescription, helping the others to give the right drug in the right form at the right time. And all of this must have discussion. And we're also including the consultants, surgeon, the internist, the nephrologist, the cardiologist. They will not decide upon something in the ICU, but we will take care of their input, indeed. And so we need integrated care, but we also need coordination, collaboration with anesthesiologists, surgeons, and other specialists. Very important, and they must be welcome in the intensive care unit, as we can learn a lot from them. The consultant is always welcome. So that's a positive aspect of critical care medicine. We are in contact with so many other disciplines. Dermatologists, ophthalmologists regularly come and see us in the ICU. But there is a boss. There is a director who can be a team player, a team builder, and a team leader. We need to learn how to have a leader in the ICU with professional recognition, credibility, promotion of the quality, vision, creativity, communication skills, interest in education and research. Leadership is action. And we need to tell the leader to be positive, to be in a good mood, but still somewhat serious. We are not joking all the time. And that's how we developed our ICU leadership courses in Brussels before COVID-19. And now these courses are on hold. But how to separate the boss and the leader, and how the leader can listen to the others. Now, can we have enough ICU doctors? I was pleased to read, no, that's another thing, but this is a study showing that if you do not have enough ICU doctors, the mortality rates may actually increase. So this is an important observation. We need to have enough ICU doctors. In the US, it's a big problem. This is an old slide, but things have not changed so much. There are many ICUs in the US without a leader. Look at this. Compare at the right-hand side, France, Germany, UK, and US. You have only 33% of intensivists with primary responsibilities. So there are some international variations, but we need to have intensivists in place. In Belgium, they need to spend more than 1/2 of their time in the ICU. It's over the time where the anesthesiologist was passing by, writing orders, and then going in the operating room. Shall we have enough ICU doctors in the future? Well, the number of ICU beds will still increase. As I like to present, the hospital of tomorrow will be a smaller hospital than today, but with more ICU beds. So the hospital of tomorrow will be a large ICU with just a few beds around it. And also we will work more outside the ICU. We need to admit patients earlier in the ICU when needed. We need to improve early resuscitation and ameliorate the continuity of care with the general floor. So I like the American concept of the intensive care unit, but critical care medicine in a broader sense. And we need to be outside the ICU regularly to try to admit some patients earlier before their cardiac arrest, before their major complication, so that we can fix the problem and the patient will leave the ICU earlier than when the patient arrives in cardiac arrest. So there is a trajectory to take care of, and this is really our role as well. We had this roundtable conference in Brussels before COVID on how to do it, how to have such a team that we should call a rapid response system, RRS. Some people call it a rapid response team, RRT, but RRT to me is renal replacement therapy. So I prefer rapid response system. Only a doctor, only a nurse, only a physiotherapist, a combination of those? Well, you can do it the way you feel most appropriate for your hospital. But the point is that we want to prevent major emergencies, cardiac arrests, code blues. We want to have the rapid response system in place soon enough. And for this, we also need to monitor the patients adequately. In our hospital, we have the extension 4444 to call for an ICU doctor right away. It's not resuscitation team, that's 800. That's code blue, cardiac arrest, or major seizures, or you need to rush. With 4444, you have an ICU consult. And, we need to arrange it because we don't want to have this team taking care of all problems on the floor. The patient has fever, call the team. No. We need primary specialists on the regular floor of the hospital. So we need to work on it, and we need some training, we need discussion with people working anywhere in the hospital. And people must identify that any form of organ dysfunction, which is not well explained, could be a good reason to call for the team. I'm not sure we need the QSOFA. I'm not a big fan of it, even though I was part of the consensus group. Some people consider that QSOFA is perhaps like SIRS. No, forget about SIRS. And QSOFA is an alarm system, but you could use the Muse or any form of early warning system. In the UK, they have done it very well. And then you can have a score, and you can call a doctor when the score is above this or that value. If you like to have a score, that's okay. That's good. And indeed, we need to be called early enough. And in the future, there will be some very small monitoring systems for heart rate, temperature, respiratory rate, and this will really help to identify patients earlier when they are in trouble. We wrote this piece on News for hemodynamic monitoring in the future. And we need to combine signals. Just a pulse oximeter on the floor is not sufficient. There are too many artifacts. But if the SpO2 goes down and the heart rate goes up, or the respiratory rate goes up, aha, now we need to do something about it to avoid a life-threatening alarm and act early with transfer to the ICU if needed. So that's the future, and we are involved in this process. It could come on our smartphone or anything else. Go to the room, 1, 2, 3, 4. The third challenge is that doctors will spend less time at work. The society is evolving and people may be tired. Sleep deprivation, many nights on call. So at the end, if people are tired, the quality of care may decrease. And we may have to allow these people to rest. Now, this will require more doctors, costs. And what about the continuity of care? If doctors spend not enough time in the ICU, they no longer know about the cases. There may be a decreased efficiency. What about the training? Training of a surgeon who does only one call every X number of days. So people discuss how we could work by shifts, like nurses, 8-hour shifts, 12-hour shifts. And that may not be optimal. One day we may have a doctor coming saying, I'm not our usual doctor. I don't know much about you, but I'm well rested. Let's be careful. And also there could be less discussions, less rounds, less seminars, and then we would need more protocols to replace the doctors. That's a risk. Too many protocols. You know, what should we do about it? Well, in the US, they think about downsizing the ICUs, decreasing the number of ICUs, and this was already expressed 9 years ago. There were too many ICU beds in some American hospitals, but not enough ICU doctors. And so this has been debated, but the question is there. Do we need intermediate care units? I'm not a big fan of these. I prefer to have larger departments of intensive care with very sick patients and patients who are somewhat less sick. In terms of organization, it's more easily managed. We could have regionalization of ICUs with transfers to other institutions. ECMO is a big example. In our ICU, look at our nurse here, we are happy to take care of these patients, but it may not be the case in a peripheral small hospital. Now remember this very interesting Caesar trial many years ago, showing that if patients are transferred to another institution, the mortality may go down. But actually, if they are transferred for ECMO, sometimes ECMO is just not done. And that's how they work in the UK. As you may know, they have ECMO centers, and it's strictly regulated. You cannot start your ECMO in any single institution. And telemedicine will change it, perhaps in the other direction, because we will have supervision from outside the ICU. And in the US, as we know, this is now implemented in many places. Telemedicine will change our world, especially during nights. It will allow us to have less doctors during the night. But it also helps us to have ICU consults more easily. to have the dermatologist looking at the skin from home with a good camera and giving an advice, or the pediatrician helping from home. Now, if we do not have enough ICU doctors, we may have critical care medicine as a primary specialty. It's a very hot topic of discussion in Europe. A primary specialty could help to combine some anesthesiology, some pneumology, cardiology, infectious disease, etc. In the US, as you know, they also developed physician assistants, hospitalists, acute care nurse specialists. That's a way to have less trained people who could help. But we also need to, of course, have sufficient incomes and increase attractivity by greater recognition. And if we want to attract doctors, this is still valid, even though the data set is quite old. Intellectual stimulation, academically challenging rounds. That's very important. In our department, we have 3 rounds a day. In the morning with those who were on call, and then the bedside rounds in the morning, where we reevaluate everything at the bedside. Very important. Need for continuity of care, more ideas, consensus opinion, group cohesion, teaching, cathartic benefits. We need to have good rounds. It's a quality assessment. When I go and visit the unit, I want to watch rounds and how they are conducted with a pathophysiological approach. It's not just cardiac output is at 5 liters per minute, so this is fine. No, we need to discuss it further. Protocols. You know, ARDS is not just a tidal volume of 6 cc's per kilogram in every single patient. No. Hemodynamic management of septic shock is too complex to be protocolized. And then there is a risk of vicious cycle. You don't have enough ICU doctors, the quality is relatively poor, you need protocolized care, but then you don't attract physicians. If nurses say everything is in the computer, you can go away. It's not very exciting. Protocols may be necessary to prevent disasters, but they do not promote excellence. I'm not sure it's a Chinese proverb, but it's well said. Look at this doctor trying to put his thoughts together. It's important, and to transmit it, to communicate it. It's part of our training. That's a true Chinese proverb. Teachers open the door, but you must enter by yourself. Look at John Marini here in our department many years ago. Look at the old pumps, but look at the young doctors. This guy makes me think at the bedside. And there is immediacy in critical care medicine. I love it. You do something, you do an echo, and you watch what this does. MIA, measure, interpret, apply. So you do a fluid challenge, you see what happens. You change the ventilatory conditions, you see what happens. And finally, humane care, distraction, not only for kids, but for any single patient. Whenever we can bring the patient outside, we need to do it. Even with an intracranial pressure monitoring system, bring the patients outside when the weather permits it. Let's be careful. With modern technology, we sometimes stay a little bit outside the room because we cannot enter with our computers. Let's be careful. We still need to go and look at the patients. And in intensive care medicine, we have a very strong relation with relatives and friends. The visiting hours are almost over now. The Relatives can come at any time, discuss with us. There is mutual understanding and mutual respect, but the family members can help to stimulate the patient, distract the patient. Now, some people are attracted by the end-of-life issues in the ICU, but some people are dissuaded by this. So we need to know how to organize these discussions and tell our younger people, are we always reasonable? For some patients, death is actually the best option because the quality of life is becoming too bad. And we need to address it with our young doctors, and we need also to preserve their leisure time. Lack of leisure time is one of the major obstacles to start intensive care medicine. We want to have our weekends. We want our loved one to be happy. We don't want to be too stressed by our profession. So we also need to maintain a good atmosphere at any time in the intensive care unit. Again, it's not jokes all over the activities, but we should be happy to work in the ICU. And we could go out together and sing karaoke, have a fondue together, drink together. When we have a good beer together in the night, on the next day, our relations can be certainly better. So we have done many parties, and we still do it very regularly with our teams, and that brings a good atmosphere. We sing, we dance together, but after all this, on the next day, we are back to the ICU together. So it's also important. Our doctors like to work in the ICU because there is some attractivity. We need to be sure that there are not too many doctors leaving the ICU for one reason or another, the burnout indeed being a big reason. Let's avoid burnout by many opportunities. And let's make sure that everybody is very proud of what he or she does. All of these are important elements. My former teacher, Dr. Weil, used to say the critical care specialist must ultimately be clinician, scientist, ethicist, teacher, and administrator. It's a difficult, demanding, but highly privileged commitment. I cannot agree with him more. This is indeed very wise, and we need to be important elements of the team, and we need to be leaders and to make sure that we provide the best quality of care to our patients. Thank you very much.